Hi, and welcome to the Changing Perspectives podcast, the show where we discuss a variety of topics including grief, parenting, health and wellness, and relationships. Join us and explore a number of changing perspectives. We're your hosts, Jenni and Josh Brennan. Jenni, episode 9.
9 is fine.
9 is fine.
Isn't that one of the rules in the game we learned the other day, the card game?
What is that game called again?
Awful. Don't play it.
Don't play that. 9 is fine. I really can't remember the name. Anyway, welcome. Episode 9, everybody. Thank you so much for joining us.
The Chairman? Is that what it's called?
I don't think so.
Okay. We'll think of it.
It'll come to me. If Jacob, our associate producer, Jacob was here, he would tell us. But, so episode 9, welcome everybody to Changing Perspectives. Jenni, do you want to give us a overview of what we're going to be discussing today?
Hospice. So I guess this is episode 2 in our Myths About series.
Oh, I almost forgot. That's right. This is the Myths About Hospice.
Yeah, and you were right. Well, actually, I think both of us were wrong. It's neither myths about ... or myths about ... It's just myths about the topic. Mm-hmm.
Right.
So this is myths about hospice. And if you listened to our first episode, you will see that I completely forgot to talk about this part of my professional background, even though it is probably the most profound part of my professional background. So all that to say, this is a topic that's very near and dear to my heart. And I feel like there's a lot of misconceptions and myths out there about hospice.
I totally agree. Can you actually just give us, even in the medical field, I work in the medical field, and even when someone says the word hospice, there are a ton of assumptions made when someone is in hospice or a hospice patient. But before we dive into those, can you just give us a quick hospice definition? What is hospice?
Hospice is end-of-life care that is designed to improve one's quality of life at the end of their life. And it's actually an insurance benefit. There's been a lot of changes to insurances, and this is a benefit that still is really quite amazing and really provides you with care for the last 6 months or so of your life. So once you have some sort of diagnosis, and the typical projection of that diagnosis is that you likely will have 6 months or left to live. If 2 doctors can certify that, then you're basically eligible for hospice care. And that's going to kind of vary on where you are in the country and what kinds of services and supports are available from you from each particular hospice agency. But it's actually a federal benefit, and it's pretty heavily regulated and underutilized.
I don't think most people know that.
That is why we're doing this today. Yeah. There's a lot of myths around it.
I'm sure we will probably address this as we go through these, but is it always a terminal diagnosis, or is there ever a situation where a patient is in hospice that, isn't the diagnosis, the prognosis isn't 6 months, or what?
No, you have to have yes and no. Right. So it doesn't necessarily mean you have to have like a cancer diagnosis. I'm not actively working as a hospice social worker right now, but when I had many patients who didn't have a diagnosis of cancer or congestive heart failure. They had essentially like adult failure to thrive. They just were no longer able to kind of meet their needs, and they were declining. And they were declining so significantly that doctors really felt like it would be very unlikely for them to still be alive in 6 months. But I also had folks that graduated from hospice. So we're kind of actually getting into some of the myths here.
Okay.
You're jumping ahead.
Sorry.
I thought I would actually talk about my hospice background since I forgot to do it.
Let's do it.
On episode 1.
Dive right in.
So it's an area of the field I never thought I would work in, and was actually working in surrogacy and egg donation when I was receiving my final clinical supervision. So when you're a social worker, in order to get your independent license here in Massachusetts and in many other states, you need to have 2 years of supervision from an independently licensed clinician. And in most places where social workers work, it's really hard to find that benefit. So most social workers are hired by an agency that says, we'll give you that supervision. We'll get you, to the place you need to be for your licensure. And then it sort of fizzles out and they say like, oh, we don't really have the supervision for you, or we need to focus on providing services. And so supervision doesn't become a priority. And so it wasn't a priority for me until I landed at this organization and had a wonderful supervisor who was very committed to social workers getting that supervision. And she had a background in hospice. And so in our work together, one day she just said, Jenni, I really think that you should think about working in hospice someday. Like, have you ever really thought about it? And I said, no, I don't want to do that. I don't want to be with people when they're dying. But it stuck with me and I started doing some research. And that day I did a little search and there was an opening for a hospice social worker 1 town over from me. And it was with the hospice organization that had taken care of my grandmother. They had expanded and now had an office near me. And I applied sort of on a whim and got the job. And it really changed my life and led me to this place I am now, where I am very passionate about end-of-life care and quality of life and grief.
I had forgotten that entire history, actually.
Well, I did too on episode 1.
Well, yeah, exactly. But I guess to talk about that a little bit more, it sounds like you might have had these same misconceptions when that was presented to you. Like, what did you think?
I did. I actually, I don't really know that here's what I thought. Hospice was the H word. It's like this dirty word you're not supposed to say. And it's just care that swoops in the final couple weeks and does all of the care for the patient and makes things a little bit easier for the grieving family.
It kind of sounds like people interpret that as death.
Right. Yeah, exactly.
Hospice means death.
You're the Grim Reaper. If you work for hospice, you're the Grim Reaper. Yeah, that's exactly what I thought.
Okay, well, would you like to go ahead and review the format for today's show?
Yeah, I have 10 of the main sort of myths and misconceptions about hospice that I'm going to run through and hopefully try to clear up a bit for folks.
Okay. So the first myth, hospice means you've given up.
Yeah, that term given up or give up is something we often hear from families when the hospice conversation happens, is they'll say things like, we're not going to have that conversation. That means that we only go down that road when dad gives up. I don't want to do that. That means that I'm done and I'm saying goodbye and I don't want to live anymore. Right. That's kind of what it's become to mean in people's minds. And it's really not that at all. In fact, depending on the hospice from which you get services, you could even still be receiving things like chemotherapy and regular blood transfusions. It really kind of comes down to cost, essentially, because hospice sort of takes over a lot of your medical care cost. And so if you're with a hospice agency that is able to fund those, then you can still continue to receive those treatments. They're probably not life-saving treatments at that point, but they're more palliative in nature. So they're designed to make you feel more comfortable, improve your quality of life. So for instance, say you have a tumor and it's a terminal tumor, you're going to die from it. There's no way to overcome that tumor, but chemotherapy will shrink it for you. That's a palliative approach. And a lot of hospices will cover that palliative measure.
So the term palliative refers to kind comfort measures, or what is I guess the layman's term for palliative?
Yeah. Interventions that are designed to improve your quality of life, improve your level of comfort.
Gotcha. Okay. That makes sense.
So you can be on hospice, you can be a hospice patient, and it doesn't mean that you're laying in bed every day, all day until death finds you.
Right.
It can mean that you're still working, that you're still going to your kids' baseball games and football games. You're still traveling. You're still entertaining and going to parties and getting medical intervention. And I think a lot of people, when they hear hospice, have this vision of someone in a hospital bed for the last 3 days of their life.
Absolutely. That's the first thing I think that came to my mind before I knew about it, before you started working in hospice, before I started working in the medical field as well. That's what I thought. I think that's what I assumed for, my grandparents when I was little, when they died.
Yeah. And think about when your grandparents were approaching the end of their life, although your grandmother's still with us. So we're not talking about all of your grandparents, but that was many, many years ago. And I think the conversation today about hospice is much more open than it was back then. We still have a long way to go, but compared to where it was a decade, 2 decades ago, hospice was even more so a taboo word.
Yes, I would say that.
So it doesn't mean you've given up. It doesn't mean that your life is over. You still very much can be fully living your life. And a lot of research shows that individuals actually live longer once they come on hospice. So once they begin receiving the additional services that they receive, because when you become a hospice patient, you get services in your home from nurses, social workers, chaplains, nurses' aides, potentially like home care workers. Some hospice agencies also provide services like Reiki or acupuncture or acupressure. Sure. So and volunteer services. So you can have folks that are passionate about hospice and just come in to be with you and provide comfort and companionship. So you're getting all of these services, and your family is getting support services as well. And so you're not as stressed. And when you're not so stressed, you actually wind up being healthier. So a lot of studies show that people live a little longer. Doesn't necessarily mean that you're cured. It's not curative, but a fair number of folks come on hospice and do better and then don't qualify for hospice for a little bit because they're improving.
You had actually mentioned the term graduating from hospice.
Yeah, I had so I've had some patients who graduate from hospice because hospice, you have to, and the regulations may have changed a little bit, but I believe initially when you come on board for hospice, your initial certification period is for 60 days, so 2 months.
Okay.
And then the doctors have to recertify you that you qualify still, that you still have a diagnosis, which if it progresses as it typically does, you will not have more than 6 months to live. So they still have to be able to sort of certify that.
Right.
And sometimes they can't. And so you don't qualify anymore. And that actually can be really hard for some families because they've grown accustomed to the additional supports and services. So a patient might graduate and no longer qualify, but then the minute that they do meet that criteria again, they can come back on hospice.
That's
so
interesting.
It's not like the window closes.
So I'm sorry, I organically have a bunch of questions. I don't want to derail your
Well, this is not
format.
A question and answer. This is 10 hospice myths, and we've gotten through one.
This is what it picks up, though, when we go through it.
Okay, we'll see.
So, yeah, our first
Why don't you hold your questions in like a parking lot, and then if they don't come up in the list, we can address them at the end.
I have a specific question, though, about the Reiki and the massage. So are there insurance roadblocks to stuff like that? Is that covered under just the hospice benefit, or how does that work?
We could probably spend an entire episode talking about insurance regulations. Typically, what hospice agencies receive is if if they have a patient on their care who's getting hospice, that patient's insurance company will pay them a daily rate. So, and you can Google and find out what each insurance company sort of pays a hospice company for their daily rate. Let's say it's $100. It's not, but they will say, all right, you have 50 patients from Medicare who are getting hospice care. You get $100 a day for each of them. Spend it how you want.
I see.
As long as you meet the regulations. But that means you have to pay your staff. You have to pay for the medications the patients are receiving. And remember, if you're a hospice that's going to provide things like chemotherapy, blood transfusions, things like that, you're paying for those.
Right.
So it tends to be the larger hospices that are able to do those things.
I see.
And a lot of those actually have a larger sort of, not grant, but like donation. So they have a lot of previous families or just donors in their area who fund those types of services like the Reiki. And they may also have providers who are donating their time for those things. So that's often how those get sort of funded.
Okay.
Did that answer your question?
Absolutely.
Okay, good.
Myth number 2. Should we go to myth number 2?
Yeah, sure.
All right. So myth number 2 is hospice means you only have a few days left.
Yeah, I think this might be one of the biggest myths is that people wait. People feel like I can't, even when they're approached by doctors or family members, right? Because we've had families, we've known people that we've talked to about hospice.
Yep.
The general consensus is like, no, it's not time for hospice yet. Hospice is like when they're dying, when they're actively dying. And the thing about that is, I mean, you could choose to do that. I've had lots of patients who come on for the last hour of their life. Great. You're getting certainly some benefit. You're getting some additional services and supports. But imagine if that patient had gotten those services and supports for the 5 months and 29 days prior to the day they died and their family. Maybe they would have had more days. Maybe they would have had more weeks. Maybe those final days would have been fuller and richer and with less pain and with more comfort and more joy for everyone involved. So it's sad that so many people kind of miss out on that benefit. To me, it's sad. Now that I know what hospice is, it's sad when people say we're not there yet.
Well, and it's maybe not, I don't know. It starting from a place of saying we're going to wait, but they don't quite understand that it's something that can be sooner.
Right. Right.
They think they can only have it in the last couple of days.
Right. Because this is part of the myth out there. This is sort of, we see it in movies and TV, like hospice literally is where they go for their final couple of days of life. And that's not the intent of the benefit at all.
Can you speak for a second on what you said about the patient or the family? Because how much does a good hospice program help the family as well?
So I would say as much as the family wants to be helped. Right. So my work as a social worker and the work of like the chaplains and the volunteers, really anybody, if there's a family member who's wanting support, we're there to provide it for them. It doesn't have to be, the wife or the husband or the daughter or the son. It can be, a granddaughter who doesn't live with the patient but is really struggling. That hospice is going to see what they can do to provide services and supports. And that might mean face-to-face services and supports. That might mean connecting them with resources and referrals in the community. It might mean things like respite. So there's an actual respite benefit in the hospice benefit that will allow, if they can find sort of coverage, it will allow and pay for families to not have to be the caregiver for a period of a few days. So you think about some of these patients who come on for 6 months and then are still alive 6 months later and are recertified again. I had patients that I was with for years. They were still dying, but they just were hanging on. They just weren't ready to let go.
Right.
And so we had them, they would just continue to decline and continue to qualify. And it can be really exhausting for a family to take care of someone like that. And so the hospice benefit can sometimes cover, like, not a vacation, but can cover a family member, the main caregiver, sort of taking some time off, taking a few nights off.
And that's what you meant by respite, right? That's
by actually
sort of a break.
Providing they can have a contract with like a skilled nursing facility or a nursing home in the area. So that patient can transfer there for, I think, up to 5 days. I think that's still the respite benefit, can transfer there for up to 5 days. And it's covered under that hospice benefit. Again, hospice isn't paying extra money, or insurance isn't paying extra money for that.
Right.
It's the hospice agency deciding how to spend their money. And so they may have funding for that.
Okay.
So
excellent.
Hospice, the myth, hospice means you only have a few days left. No, you could have months left to live.
Right.
And maybe even longer, because you could sort of outperform what doctors were thinking.
Do you think there's a deficit in the I don't know, the way that hospice is explained in the hospital setting?
Yes. So, and I say yes pretty deliberately, because I've been at some trainings where oncologists have gotten up and said, we as doctors don't do this very well, because to them, bringing up hospice, talking about death is like saying we've failed as your medical community, as the providers who are saying, here are your treatment, here are your curative options. We haven't been able to find one that's going to save your life. And so saying and exploring hospice options feels like defeat and feels like failure for them. And these oncologists that I've heard talk about this really own that's their own issue. And that does sometimes get in the way of patient care and prevents them from having these conversations earlier, because ultimately they're the ones that can help change the myth around things like this, like these conversations we're having, conversations we have with friends, conversations we have with family members when, they wind up with a terminal diagnosis or a friend of a friend. That can change things too. But if you don't have access to that, if you're not seeking that information out and you don't have folks in your circle who have this hospice knowledge, where are you going to get it from? Maybe a Google search if you think ahead, but otherwise it has to come from your medical providers. And
Absolutely.
if they're not willing to bring it up because it feels like a failure, but also they're not willing to bring it up because it equals death and they don't want to scare you.
It's like this vicious cycle.
It
Did
is.
you say that already?
I didn't. No, but it is a vicious cycle. And I think it takes a lot of bravery for someone to bring it up, to bring up the word hospice.
I feel like this should be happening in the terminal diagnosis discussion, the conversation when the oncologist, or we keep referring to cancer, but whatever the specialist is having this discussion about this terminal illness. And you say, okay, here's what the plan will be. Here's the plan of care. Here are the things we're going to do, make things better or make you more comfortable during this last 6 months. The other thing is this wonderful program called whatever, and it happens to be a hospice program.
I would even say earlier, at the time, anytime there's a conversation around treatment options, I think there should also be an acknowledgement that a treatment option could be no treatment. The decision to stop treatment or withdraw treatment because of a quality of life issue. Right? Because we'll use the cancer example. I think probably all of us have known someone who's been in the end stages of a cancer diagnosis. I don't really like to say fight or battle. I don't know. I just don't like that. That's a whole other episode. Right. But we've known someone and we know what those side effects of treatments look like. We know what the lasting sort of changes to their quality of life are. And I think there's room for the medical community to say, look, here are your treatment options. Here are the side effects. And here's what it might do to your quality of life. So this treatment might give you 3 extra months, but those might be 3 really awful months.
Right.
Or we could look at hospice and palliative care options for you. You know, that's also an option. But that's a hard conversation to have. So I get it. I get why it's still something to be learned in the medical community. And just like we were talking on another episode recently about grief and how professionals don't have to take a class in grief.
Right.
Doctors and nurses don't necessarily have to be very well versed in hospice and the hospice benefit and how to have those conversations. It might just be a little piece of their training. And so,
well, it's the same. The same is true for organ and tissue donation. You know, a lot of the time, the nurses and doctors we work with every day don't have a lot of information about organ and tissue donation at all. So they have to rely on the local professionals in their region to give them information about it. It sounds like it's the same for hospice programs. And
let's be honest, all of those professionals also have access to their own personal experiences and stories they've heard from people they know and people that know people they know and watch TV and watch movies. And so some of their perceptions might just be wrong. Mm-hmm. And so these are why this is why these types of conversations are important, and why I think it's also important for the hospice agencies to be doing outreach to the community. And I think a lot of hospice agencies are doing that, trying to forge partnership with hospitals, partnerships with physicians, educating them around what hospice really is, to try to sort of change the general consensus around the H word.
And it's clear that that's where this conversation should take place, is that initial discussion with your doctor.
I think so.
Right.
I think so.
So myth number 3, we've touched on a little bit already, but can you address that? So it says hospice is only if you have cancer. Clearly not the case.
Yeah. It's any diagnosis or condition in which the typical progression of that diagnosis is likely going to result in you not surviving beyond 6 months.
And you had mentioned failure to thrive, and that's kind of a weird sort of catch-all diagnosis, right?
And I actually think it's been removed recently. I think it might not be a qualifying criteria anymore.
I think I remember you talking about that. Mm-hmm. But failure to thrive, or whatever that condition is referred to now, is sort of the end result of maybe a long, I know you don't like this word, but battle with COPD or some sort of progressive lung disease or congestive heart failure.
Yeah, but a lot of diseases and diagnoses like dementia or CHF or COPD, there are specific like gradings and levels of diagnoses which
that qualify?
Yes, exactly. Like you have to, a diagnosis of dementia or Alzheimer's isn't a qualifying criteria. You have to be at a certain kind of progression of that disease in order to qualify.
I see.
And these are medical doctors who are making those decisions. Right. So actually sitting down, reviewing the patient's chart, reviewing their labs, talking about their history, nurses doing evaluations, and then the team and 2 doctors, usually it's the, patient's physician and then the medical director of the hospice agency, really certifying that, yes, this meets criteria. And hospices are really good about that, because if they admit a patient who doesn't meet the criteria, well, when the insurance companies, because they're getting money through federal insurance like Medicare, when the Center for Medicare Services comes in to do an audit, they're looking to make sure that you're not providing services as a hospice agency to someone who doesn't need it, and that you're not graduating patients who shouldn't have been graduated. So that's what I'm saying when I say it's tightly regulated. I'm talking about that. Right. So it's certainly not just cancer. But if you look at sort of the history of it, I think we as Americans were more open to hospice for cancer patients, because those were the types of diagnoses where we were more comfortable talking about death.
Right. And it's, folks, I think, the general public understands the terminal nature of cancer more than they do other medical conditions.
Exactly. Yeah, I think you're right.
So myth number 4, this seems like a tough one. Hospice is really assisted suicide.
Yeah, I think that this is another big myth out there, is that people feel like when you elect your hospice benefit, that essentially the hospice providers are coming in and doping you up. Helping you die.
Right.
Like doping you up on meds so that you die faster, so that it's hastening death. It doesn't hasten death.
Where did that come from, you think?
Well, I think if you look, I'm not a nurse, I'm not a doctor, but my understanding is that the use of morphine as a painkiller in higher and higher doses does actually slow your respirations. And so I think it comes from that. I think,
so
and it's also
just, they see something, they assume they know what they're seeing.
Yes, because here's what it looks like, right? It looks like grandma's been sick. Grandma has what we call terminal agitation, as oftentimes as people are actively dying and actively approaching the end of their life. It's almost like their skin is crawling. I've never experienced it myself, so I can't say for sure, but just in sitting with the patients I've sat with as they died, that's kind of how I would describe it. It's as if they feel like their skin is crawling and they're just really agitated, uncomfortable, irritable, just really suffering. And so it's referred to as terminal agitation. And so, grandma gets really agitated and restless. And so the hospice nurse comes in, gives the final push of morphine, which is what it's often referred to sort of in the pop culture, I guess.
Okay.
The final push of morphine, and then she's dead. So it looks like the nurse killed her with the final push of morphine.
But the hospice nurses aren't coming in and saying, I'm giving her the final
No, that's
dose.
Illegal. Yeah. No, they're not saying, I've never seen a nurse say.
So it's the family's interpretation.
That. Right. And again, this goes back to the conversation we had the other day about organ and tissue donation and someone being in the emergency room and the front of your brain shutting off. It makes sense. These families grief brain. Families aren't fully aware of what's going on. So what they see is grandma is restless, but looks very much alive, and they don't understand those are really the final stages of life right there. We as the death professionals get it, and we're not surprised to know that she's going to die an hour later. Right. And we might communicate that to the family, but that doesn't mean that they hear it. So they see grandma looking very alive. They see the nurse come in, push morphine, then grandma's dead. The way they make sense of that is that medication just killed my grandmother. Right. And so then that's what they say. They say to their friends, don't use hospice. They killed my grandma. I've heard that a lot, when we would have families come to us or patients come to us, there would be some resistance sometimes because families would say, you're just killers. You just want to kill my grandmother. You just want to kill my dad. Oh. You just want to kill them. And I get where that comes from, but it's not true. Hospice doesn't hasten death. Hospice makes you more comfortable. Right. And so I get it. It does look like the medication is killing you because the medication is making you comfortable.
But it's the job of the medical community and the hospice professionals to do the best job they can to explain what's going to happen, what they will see.
Right. And that
be as transparent as possible.
And some families don't want to know that. Some families, when we would sign folks up for hospice and kind of go through everything, some families wouldn't want to hear, what does active death look like? And we would provide them with that written documentation and offer to have the conversation with them. But often they didn't want to know. They didn't want to know what it was going to look like in the last day, the last hours, the last minutes. They didn't want to know what the body was going to look like when it was no longer alive. Right. And that's a tricky thing because we can't force people to listen to that. And it would be, I think, better for folks if they had a better understanding, because death doesn't actually look like it does in the movies and in TV. I've seen very few deaths where the patient, looks around at the room and says, I love everybody. I'm going to miss you. Go out there and find great adventure.
Right. It's not a Disney movie.
And then just falls asleep. Like I have seen some beautiful deaths, but not every death is like that. And I think a lot of families expect it to go like the movies.
Yeah.
And it's not at all. And so you're right. To your point, it's the medical community, the hospice providers, it's their responsibility. But I also think it's kind of our responsibility as sort of the collective community to have more honest conversations and more honest depictions about end of life.
Well, I think that leads nicely to the next myth, which is my doctor will tell me if we need hospice. And that, I think, speaks to what you just said. It's our job to sort of reach out and know what happens or ask questions, right, as the patient's family.
I think it's a lot like the conversation we were having about the grief process and how people that are grieving have these expectations of their support system, and the support system has these expectations of the people that are grieving, and both kind of wind up expecting the other to be mind readers. I think that's doctors and patients and families. The doctors tend to say, like, when the family and patient are ready to talk about end of life, they'll ask me. And the family and patient think, when it's time for hospice, the doctor will tell me.
Right.
And so I think that there tends to sometimes be this disconnect. And I know I'm talking in very generalized broad strokes right now. I'm not by any means trying to say every doctor does this or every family does this.
Exactly.
I'm saying sort of overall, that's kind of the pulse check of where we are as a society, as a culture with hospice. And hospice is still relatively new. It was founded by Dame Cicely Saunders in England. And she founded it in the 60s because she had had a number of losses herself, and she witnessed a lot of people that were very close to her suffer at the end of their life. And she became very interested in how can we make death less painful? Like, how can we actually find their way to be quality as someone's dying? And so that's where hospice came from. And then like 7 years later or so, the early 70s, the first hospice in the United States opened. So we're talking hospice has only been around since the early 70s. It's only slightly older than you and I. That's still really new. That's a new concept. And so this is, and death is a very taboo topic in America. And so the fact that we have so many podcasts that are talking about grief and death, this is new. You know, our willingness to kind of have these conversations, it's new. So we still have some room to go there.
So can we do a whole episode on how you become a dame?
Oh, I don't know. I think
that's the second time it's Dame Judi Dench, right? Like magnificent, wonderful actress. And then Dame, what's her name?
Cicely Saunders. Well, if someone knows the answer, post that on our pages.
I only know two dames.
I guess I never thought of that. That's how your brain works. Mine doesn't. I was like, whatever. She's a dame. No big deal.
You can rely on us for talking about tough stuff, and you can rely on us for throwing in a little laughter every now and then.
And nonsense.
Okay.
I guess that would probably serve people well in Jeopardy.
Yes.
Okay. So if anyone knows the origin of how you become a dame, go ahead and post that on our Facebook or our Instagram page.
Please do.
Yeah.
So I wrote a little note next to that myth as I was going through this, and just take control of your own medical care, your family's medical care, ask questions. I feel like a lot of people, maybe they're a little nervous, a little scared when they go to the doctor's office, and I think it's important to understand that doctors are humans.
Yeah. And I think that there is a generational component there. I think that the generation before us and then those before them.
Baby boomers?
I don't know. What we are.
We should do a generations episode.
Okay. You just made me lose my thought. So the generations before us tended to, and so still do, tend to like revere doctors as if they are gods. And listen, if you're a doctor out there listening, 1, thank you for doing what you do. And 2, thank you for listening to us.
One of our besties is a doctor.
I know. Yeah. And 3, I'm not saying you're not gods. What I'm saying is that people tend to like revere their doctors so much that they would never think to say, I'm going to bring up hospice. Because it's like this level of respect. Like, I'm not going to suggest to the doctor what they should be recommending, but also they sometimes then don't feel comfortable asking their doctor. So you and I know lots of people from those generations that will go to the doctor's office and then come back and we'll be like, hey, what'd they say? And they're like, I don't really know. I wrote it down. Here's what it said. Well, what does that mean? I don't know. I didn't want to ask. They didn't have a lot of time. So the younger generations have become maybe a little too empowered. You're right. We should talk about generations. Have become much more empowered to be able to say, I think, to those positions of authority, like a doctor, hold up. What does that mean? You just said stage 4. What does that mean? Can you explain that to me? I don't understand it. Mm-hmm. And so also feel a little more comfortable saying, tell me about hospice. When does that become a benefit? When does that become something we can talk about? So I agree with you. We should be taking more of an active role in our care and in our loved ones' care and encouraging people to ask. So if you are starting to think about maybe this is something that I would qualify for hospice for, or my loved one would qualify for hospice for, it's okay to ask. It's okay.
Absolutely.
It's also okay to self-refer to a hospice agency. They'll then have to get records and information from your doctor, but you can reach out and make that inquiry yourself.
So I think you addressed that a little bit in the last myth, which we'll get to. And so I think we're on myth number 6, which you've talked about a little bit. So it's
right, because you dragged us ahead.
I did. We're jumping around.
I know.
It's okay. Once you choose hospice, you have it until you die.
Right. So I did address this one. Yeah. Once you access your hospice benefit and doctors are saying it's likely that you have less than 6 months to live, you have to then recertify every certification period. So that may be an initial period of 60 days, and then it may be every 3 months, or it may be every month, kind of depending on the regulations there. If you don't meet the criteria at some point in time, you graduate, you no longer qualify for that benefit, but the hospice agency will transition your care to other providers in the community for you. Mm-hmm. And then at some point, you likely will then meet your hospice criteria benefit again. And so you can come back to hospice. But also you can come on board hospice and then say, you know what? I don't really want this. I know I qualify for it. I believe it could probably improve my quality of life, but I don't want this right now. And I had folks that were really active. You know, they had a terminal diagnosis. They qualified for hospice, but they were younger. Had young kids, had jobs, had active lives, and didn't want sort of the added stress of having to have another sort of agency involved in their care. They just weren't kind of ready for it. So you could then decline hospice services.
So is there something in between? So can it's a yes or no to hospice, but is there a yes, but I don't need you once a week? Can you come?
Oh, sure. Yeah. I think there is a minimum requirement for nursing care. I think the nurse has to lay eyes on you.
Right.
There's a sort of minimum there because they're doing your medication management there and checking your vitals and stuff like that. But so as a social worker, we would have patients and families that would say, I don't want social work because, I think social workers are just here to take my kids. So I don't need a social worker.
I smell another myths about
social workers. Or I don't need a chaplain because I'm not Catholic. Or I don't want to volunteer because I don't want strangers in my house. Or I don't need a nursing assistant because I don't want anyone helping me bathe. You could do that. You can kind of pick and choose your services for sure. The only required service is the nursing piece, I believe.
Makes sense.
And I'm saying I believe, and I'm qualifying this because I haven't been a full-time hospice social worker for a few years now. Right. And so the regulations may have changed.
Okay. Hospice is a place. Myth number 7.
Right. So I think a lot of people say things like go to hospice. Right. When they're dying, they will go to hospice. Hospice can be a place. So some hospices have inpatient facilities. Either they have contracts with local hospitals or they actually have a building or a house where folks can go when they meet a certain level of criteria. For some of those, that might mean that they're very kind of in active end stages, within a few days. For others, they might be more lenient a little bit around it, and that's okay too. So sometimes it's a place, but sometimes, and most of the time, it's not. Hospice refers to the services that you're provided, but the family is still the caregiver. And this is actually myth number 8. So I'll talk about myth number 7, which hospice is a place, and myth number 8, hospice will become the caregiver together, because I think that's a misconception. I think the misconception is that I will go to hospice and they will take care of everything for me, and my family can just come and be my family. And your loved one may qualify for that. There may be the hospice in your agency that provides that, and there may be bed space. If you may, though, however, live in a place where that's going to be harder to find, harder to qualify. And so hospice is going to be the services that come into your home, but they're not there to be the caregiver. They're not there to replace the caregiver. They're not there so that, 24 hours a day, a nurse or a nursing aide is taking care of your loved one. The family remains the caregiver. And so I think that's also a big misconception. And people think like, oh, okay, H word. So grandma's, in her final stages here. We're ready for hospice. She's got a few days left. Someone's going to come in and take care of everything for her.
Right.
That's not
24/7.
24/7. That's not true. And that can be a huge disappointment for families who maybe waited a little longer than they would have. And so by this time they're exhausted, they're burnt out, they've used all their sick time from work, they're accessing their FMLA benefits from work. They're just at the end of their rope, and they're thinking, all right, at least hospice is coming, right, and they're going to take care of all of it for me. They're going to be there to support you, but the vast majority of the time, unless there's, a really heightened need and the patient needs sort of one-on-one nursing care for a safety issue, you're alone with that patient as a family. It's up to the family to be the caregiver. And so that catches a lot of families off guard when they have this assumption that hospice is a place and or hospice becomes the primary caregiver.
So where did that come from? Was it in the past, maybe 10, 15 years ago, it was just hospice houses, or where did that come from? Were there more of them?
I think a little bit of all of that. I think that hospice used to be accessed more often at the very end of life when people maybe were having symptoms that weren't controlled so well. And so
were admitted somewhere.
So they had to be, yes. So they were already perhaps in the hospital, and then there was like a hospice team. But also insurance regulations have just become tighter over time, right? So I think if we're talking about what hospice looked like 10, 20, 30 years ago, it probably wasn't as strictly regulated, and there probably wasn't as much of a sort of cost sort of piece there.
So to review, for the most part, the majority of hospice patients now are in their own homes, and the hospice agency comes to the home.
Yes, or their own home may be a nursing home, right? So they may already be living in a nursing home, and the hospice agency will come and provide services in conjunction and in coordination and collaboration with the nursing home. So hospice will provide services in wherever the patient calls home.
Gotcha. So there's also, very rare these days, but also hospice facilities.
I wouldn't say very rare. I actually think they're becoming more common.
Oh, really?
Especially with bigger hospices that have better sort of private funding.
Okay.
Because it's just... Gosh, it's just so much
expensive.
nicer. Well, it is so much more expensive for sure. But, if there's an option and a patient is willing to not be at home, but to be in a home-like environment where there are more caregivers, it's really quite beautiful. And if that is something that's important to you, you want to look into hospice homes or general inpatient hospice facilities. It's something as a family you should look into ahead of time.
So, in the hospital setting, you've got hospice agencies that have like a contract or an agreement with that specific facility to have inpatient hospice
Yeah,
patients?
and sometimes that hospital will have their own team.
So I was going to ask about that as well, because I know with my work in my field, I'm familiar with a multitude of different units at hospitals. I know that a lot of hospitals have hospice units, but it's not maybe a hospice agency. It's just...
It tends to be private rooms. So it tends to be sort of a quieter area of the hospital, maybe a quieter end of a hallway that are like, it's the hospice unit, it's the hospice wing, it's the hospice rooms. They're private beds usually, because that allows for a patient to not have to have another patient in the room with them, and staff, hospital staff, medical staff who are comfortable with end of life care.
So hospice can look
very different.
Very different.
And so that is I'm going to jump down to...
That's a good idea.
Myth number 10, which is, it doesn't matter which hospice I choose. Like, hospice is hospice. It doesn't matter. That's not true at all. As Josh is sort of getting and pointing out here, hospice can vary very greatly depending on kind of where you reside. There can be small kind of boutique hospices, and there can be, that maybe have like 5 or 6 patients at a time. And there can be large hospices that have thousands of patients at any given time, and lots of offices. So I always encourage people to really research the hospices in your area. Check out their website, get some information, meet with them. You don't have to just sign up with them. You can call and say, can you come out and meet with me and go over, like, just do a sort of informational session with me and my loved one.
And there are a multitude of different hospice agencies for one particular region.
Yes. Right. I mean, I think in more rural areas of the country, your options might be more limited. I can definitely envision a situation where you really only have one hospice choice. But you still can individualize your services from that hospice.
Okay. So the final myth, kind of a big one, I think. It says you need a DNR. And I don't know what that other word is.
MOLST. So here's some lingo to sort of break down for folks. Folks may have heard of a DNR, which stands for a do not resuscitate. And a lot of older people, like, this might be a form that your grandmother keeps in her icebox. A lot of older people, that's where they would sort of keep these. It's a document, a legal document, which one can sign at some point in their life that says, if something happens to me, if I have a heart attack, if you find me and I'm not responsive and I've signed this DNR, I've signed this do not resuscitate order, that means don't save me. That means I don't want CPR. I don't want life-saving measures. I don't want... And CPR is very violent. It's, again, not how we see it on TV and in the movies. It's extremely violent to get, if CPR is done correctly, you're going to walk away. And if you're someone with a terminal condition, and you've undergone chemotherapy or lots of treatment and you're just generally weaker, you're going to walk away with a lot of broken bones, a lot of bruising, maybe some other injuries if the CPR works. So I think that's important to say. And that is another episode that we'll have coming up, is these sort of specific end of life discussions. But so that's what a DNR is, a do not resuscitate. It's evolved over the past few years, and we don't see folks using a DNR form a lot. It's become a MOLST form, which is a medical order for life sustaining treatment. Both of them have to be signed by the patient and a doctor. But the MOLST is a little more broad. It's more of an open-ended sort of discussion. Like, I don't want CPR, but I would like an IV. I don't want intubation, but I do want CPR. It's really, it initiates a more comprehensive discussion with the patient around what they want in terms of interventions at the end of their life. So to relate this to hospice, there tends to be a little bit of a myth that I'm not ready and I can't sign on to hospice if I don't have a DNR. Like, if I'm still someone who wants CPR, I want to be intubated, I want IV, I want you to try everything you can if my heart stops, then I can't be on hospice.
That's a myth.
That's a myth. However, because every hospice is different, a hospice may have a policy.
So I'm familiar with the term, DNR, DNI, do not intubate, but also advanced directives. So is that the same as the MOLST?
These are examples of advanced directives. The MOLST form, the DNR, examples of advanced directives.
So we can, I guess, address advanced directives at a different time.
Yes.
But it includes a bunch of different decisions that you should think about towards the end of of life.
Yeah. So, but the myth here is that you don't necessarily need to have a signed DNR or a signed MOLST form or be okay with sort of withdrawing all care in order to be eligible for hospice.
That's a big point for folks to realize. I think that a lot of people just assume that hospice equals DNR.
Yes, for sure.
Okay, so I had just a couple of quick follow-ups. That was the end of your myth list. That was a good list.
That was the end of my list.
Yeah. Can you quickly just review, maybe just in a phrase each, what the roles are in a hospice agency? You've been referring to a handful of them: chaplain, social worker.
So, and this is going to vary from hospice to hospice, like how they actually break up their team. But there's the nurse who is responsible for face-to-face care, things like medication, filling your medication, or helping you with your medication, sometimes administering that medication, helping with medical concerns. So the goal is when you come, or one of the goals, when you come on hospice as a patient, you don't have to go to your doctor's office anymore. You don't have to go to the hospital. That pretty much everything can be treated in home if you'd like it to be treated in home. And that happens via the nurse. She or he is the nurse case manager who's overseen by the medical director. So they kind of take over the medical part of your care. And then you also have access to a social worker or a social worker team who's there to provide all sorts of services for you, potentially or connecting you and your you and your family to resources. Maybe you need financial assistance with things. Maybe you need assistance connecting with a funeral home. Maybe your family needs help finding a therapist. Or maybe you just want the social worker to come and sit with you weekly or a few times a week to talk about end of life, to talk about what's important to you as you're approaching the end of your life, or what's important to your family member as you're approaching the end of your life. So I've provided services to sort of the whole range, whether it's a child who's losing their parent, or a grandparent of someone who's dying, or the actual individual, or their spouse. But that's sort of the role of the social worker, is to provide that social emotional support to the patient and to any of their loved ones. The
system.
Anyone. Yeah, they're really support system. It could be like their neighbor who's their best friend but is really struggling. Then the chaplain is there to provide all patients, regardless of denomination, regardless of whether they have a denomination at all, or whether they find themselves religious or spiritual, is to be there to provide sort of a resource for those spiritual factors in life, those spiritual discussions that folks might want to have at the end of their life. And also, sometimes depending on the hospice agency, potentially be able to perform last rites.
Okay.
If you are of a denomination where that's important, either they can do that themselves for you, or they're going to have contacts in the community to be able to have that, those sort of sacraments for you.
Thank you. And I think you mentioned hospice volunteers.
So the volunteers are required. So under the federal guidelines for hospice, each hospice has to have a certain percentage, a minimum percentage of their service hours, every hour that they provide to hospice patients, a certain number of it has to be provided by volunteers.
Interesting.
And so there's flexibility in terms of how they do that, but hospice volunteers then they basically have to go through pretty intense training, as if they were becoming an employee. And they may, in some hospices, they would use their volunteers. Actually, in one hospice, they believed that no one should ever die alone, which is really, really beautiful. And sometimes just logistically, families aren't able to provide round the clock, awake bedside care. And so when we knew that a patient was actively dying and was within, 24 hours of their death, the volunteers would provide coverage to sit at the patient's bedside so that
that's amazing.
They wouldn't die alone. We couldn't always guarantee it, but it was really beautiful. So that's how they use their volunteers. If the volunteers were open to that, they'd go for like 3-hour shifts and just sit next to this person who was likely going to die while they were sitting there, but they wouldn't die alone. Other volunteers come and provide, maybe house cleaning services or just talking to them. Or if there's someone who's trained as a Reiki provider, they might come in and that might be what they do as their volunteer service. But it is a very large portion of every hospice agency. Another regulated area or required area for hospices is bereavement support. So hospices have to provide bereavement grief support to not just hospice patients' families, but to the entire community. And so there's a little known fact, right?
Yeah.
That if you are someone grieving in the community and your family member, your loved one never accessed hospice, you're still eligible for bereavement support from your local hospice agency.
Wow.
Now, there's not a lot of requirements on what that bereavement support looks like. So some hospices provide really intense bereavement services. They have groups, they have individual services, they have events every, couple months or so. And others, their bereavement support, all they're kind of able to sort of financially support is mailings a couple times a year. This is, again, speaking to the fact that every hospice is different.
Right.
But that is another sort of part of that hospice team. And then you've got nursing assistants and sort of personal care attendants who are able to go in and provide personal care, bathing, toileting, things like that to patients. So families don't have to do it all the time. And we might be talking about a couple hours, a few times a week for that.
Right.
I don't think I missed any hospice team members, but if I did, definitely post that on our pages and share your hospice role.
Well, I just want to say how amazing hospice programs are in their care and concern, and just it's such a special field that not everybody can work in. I've had a lot of contact with hospice agencies in my work history, and nothing but really nice, excellent, very professional people that really care about the work they do.
And I think almost every hospice person that I've ever met would say, whenever we would tell people what we would do, there would be that like, oh, you're so special. It takes an angel to do something like that. And I think most of us always feel like we get more out of the work we do. Like we get so much out of it that it feels we feel a little guilty at times. Like this work is
rewarding.
It's so rewarding and so beautiful and also so challenging, but to be able to be allowed into that sort of sacred space at the end of someone's life, not just in their final moments, but in their final moments. It's a beautiful thing to be with someone and to be with their family when they're dying. Right. When they take their final breath, that's a really intimate moment. And so to be allowed into that space is quite an honor. But also to be with families as they're going down that road, approaching the end of their loved one's life, that is really special. And so I think a lot of us feel really lucky and honored to be a part of that.
Excellent. Well, thank you for taking us through the myths.
You're welcome. And I'm sure there's more myths. So if there's other myths or other things, we can continue that online.
I'll add a quick, tiny myth that connects us to one of our previous episodes. Hospice patients can still be donors.
Yes, that's true. That's true.
Yes. I think that's pretty much it. Do you have any final thoughts?
I would encourage people to actually do more research about this, to go to the links in our show notes.
I have a couple links to share. So, Hospice Federation, that's hospicefed.org. And then there's the Hospice and Palliative Care Organization, And that's kind of a lengthy link, so we'll put that in the
they'll be in the show notes. But
right.
I think it's a good idea to have these conversations with your family members, not just anyone who has a terminal condition, but just in general, like share this information. So I was listening to this podcast about hospice. These were some of the myths they talked about. Have you guys heard these myths? What do you think? What are your thoughts on hospice? Because I'm willing to bet for a lot of you, you may have family members or friends who might say hospice is awful. They kill people. Yeah. And so you're entitled to those feelings and you're entitled to your beliefs. And I don't know what's happened exactly in everyone's life. So I'm not saying anyone's wrong. I'm saying let's talk about it. Let's talk about some of these myths and where they come from and what a lot of the research shows.
All right.
Okay.
Well, that is going to do it for today. Thank you guys so much for listening. You can learn more on this by checking out the blog post called The H Word on I'm getting tongue-tied. ChangingPerspectivesblog.com. Again, it's called The H Word. Check out the Hospice Federation, hospicefed.org, and Hospice and Palliative Care Organization. We will share those links in the show notes. Changing Perspectives is coming at you twice a week now, Mondays and Thursdays. Look for new episodes in all your podcast platforms. And just as a reminder, this episode was for education and entertainment purposes only. Should you need additional support, please contact your healthcare provider for information and referrals. Please follow us on Facebook at Changing Perspective Podcast and on Instagram at Changing Perspectives Blog. Once again, please check out our website, changingperspectivesblog.com, or please send us an email to changingpodcast@gmail.com. Go ahead and subscribe to the show so you never miss an episode, and we will see you next time. Say bye, Jenny.
Bye, Jenny.
The Changing Perspectives podcast is produced, recorded, and edited by Dizzy-Bird Studios, Whitman, Massachusetts. Visit Dizzy-Bird Studios on Facebook, facebook.com/Dizzy-Bird Studios.